So we are going to begin with the next session, that is research in MBM. So we have the moderator, that is Dr. A.G. Unnikrishna, who is an endocrinologist in Pune. Dr. A.G. Unnikrishna, he is a MBBS and MD in endocrinology, DMB, and NANMAS. He's the CEO and Chief of Endocrinology at the Chalaram Diabetes Institute at Pune. He's a former professor, Department of Endocrinology, and Amrit Institute of Medical Science, Cochin. He's the co-author the largest multi-center study of subject with pancreatitis and pancreatic diabetes worldwide. More than 190 pumped indexes publications. The awards are, like he has a fellowship award of the RSSDI in 2017, for Diabetes Association of India in 2018, and the Diabetic Excellence Award at Digital Diabetes Summit at Hyderabad in 2019. Recently, sir, in 2020, he delivered the Madhukumbha orientation at the Annual Diabetes Association meeting at Nasik, Maharashtra. I request sir to proceed further.
Thank you for the kind introduction. I hope I'm visible and audible.
Yes, sir, you're visible and audible to us.
I'd like to thank Dr. Vaishali and Dr. Chetan for this wonderful conference and the very kind introduction. I think we have an excellent session coming up in the afternoon now. And this session is going to be on research in mind-body medicine. I understand the first speaker is Dr. Shivrama Varamballi. May I have his CV put up? Dr. Shivrama Varamballi is a professor at Synapse and has an interest in yoga, in the treatment of psychiatric disease, and also in various disorders of mental health. He's well published and has an excellent academic reputation. And I've seen some of his publications on PubMed, and they're truly inspirational research work with regard to yoga and psychiatric disease. He's going to speak to us about the neuroscience of yoga, implications for endocrinology. Over to you, Professor Shivrama.
Yeah. So what I'm going to try and do in the next maybe 20 minutes is to try and see what, as everybody in the morning has been saying, including Professor Norman Sartorius, is that there are commonalities between all the NCDs and yoga. Although many people talk of yoga, we have to look at what actually it does and how does it do it, so that it becomes truly scientific and not just a belief system. So what I'm going to talk about is, as Dr. Norman Sartorius said, we are now have to be worried about wellness, not just illness. The medical profession has to look at more than just treating disease. And positive mental health is a big part of this. But first, we have to understand the brain systems and neuroplasticity. Everybody talks about neuroplasticity, but how to improve it, or rather bring it back to a state where the brain can take care of itself, is something we need to understand. What yoga can do for this, and the mechanisms of action of yoga, and the implications for endocrinology. And so, if you ask, this is a responses taken from when people are asked what they think is positive mental health, and they say, okay, some people happiness, well-being, being satisfied, being positive, finding meaning or meaningfulness, and ultimately allowing the person to express her or his full personal potential. Now, why is it important? We have been told again yesterday and today that, it was recognized back, thousands of years back, that only if your body and mind both are healthy, then a person can be called as healthy. And that if you are mentally not healthy, it is impossible to be physically healthy, and the reverse also is quite true. And for example, when we were MBBS students, we used to think that the brain is a very, a non-plastic organ, or a very, when something happens, it's very difficult to reverse. But now that we know that it is not true, and diabetes and depression, so many people have spoken about it. And such important issues can't be, of course, left to Hollywood to sort it out. So we have to look at more people who have actually done work. And this is a very interesting, this is some time back, it's around 10 years back, but this man is considered as the happiest man in the world. He is actually a geneticist who then became a monk, a Tibetan monk, and his brain showed some waves which nobody had ever seen before. And he, of course, says that it's not very difficult. What I have done, everybody can do. Unfortunately, we all exercise our body, but we don't exercise our brain. And he says if you do it daily, happiness and suffering both can be resolved scientifically by exercising our brain. But how do we do that? Now, the current understanding of brain circuits, for example, like I said, some people compare it to a computer. A computer also does a lot of work like the brain, but it does not have the flexibility of the brain. So in the computer, if a chip is burnt, you have to replace the chip. And the computer cannot reallocate the work of that chip to another chip. That is what the human brain can do. So I have a stroke. This is something I cannot speak. Most people by the end of 2-3 months learn to speak again. How does it happen? The brain reallocates that job to some other part of the brain. So there is a lot of reserve in the brain. Commonly people say we only use 10% of our brain, 20% of our brain, 30, whatever it is, that there is a lot of reserve which comes down with age. So children are incredibly plastic. Something happens to a child neurological, you can be almost sure that it will recover. Something happens to us when we are 90, yeah, very unlikely that we will recover. So this plasticity is important. And also we used to be taught that there are areas of the brain for specific functions, speech area. Now we know that areas are not so important. It is networks which are important. So the area, of course, connected to many other areas, and these networks, there is a network for memory, there is a network for happiness, there is a network for sadness. So like Dr. Gangadhar was talking, the amygdala or the limbic system controls emotion. So there is a network for emotion. That is what we have to understand. And Donald Hebb is considered as one of the persons who brought about this term neuroplasticity, and he gave a very simple rule which is called as the Hebb's rule in neurology, which says neurons that fire together wire together, and neurons that are out of sync lose their link. Which basically means that if you do something repeatedly, that circuit becomes stronger and stronger and stronger. On the other hand, if you don't, that link goes away. So this is the basis of our ability to rewire our brain. So if a person is sad for a long time, he becomes an expert at being sad. So he is very easy for him to be sad. On the other hand, if a person is very happy all the time, it becomes natural for that person to be happy because that is the circuit. So this is what we have to understand. And you can see, for example, we have two kinds of memory. One is called as implicit memory, which is our walking, cycling, swimming. You never forget it because the circuits are so deep rooted. Whereas the other, somebody's name, I am introduced to somebody today, remembering that is not so easy because this is semantic memory. This is not implicit memory, right? So that is a different kind of memory we have to train again and again and again. Now, what are the ways in which we can train or improve our neuroplasticity? Yoga, as Dr. Indranil Basure was saying in the morning, unfortunately, when people talk about yoga, they forget meditation. So yoga without meditation is like physics without mathematics. It cannot happen. So when Iyengar, for example, Iyengar schools teaches meditation within the asana. You need not meditate separately. No, it's the meditation. As long as you focus on what you're doing, be mindful, focus on breathing, that is meditation. Some of the other ways which have been is intermittent fasting, which is now basically intermittent fasting is putting gap between two meals. Some people, of course, fast 24 hours in a week. That's another kind of intermittent fasting. But most commonly, what is done is between, say, dinner and breakfast, or say, for example, if you don't have breakfast, you have dinner and then you have lunch. If you give time, what happens is the brain gets time to do other things than digestion. Otherwise, the brain is preoccupied with the whole thing of vagal thing and digestion. So this is something. Having novel experiences, doing new things, learning new skills is another way of increasing neuroplasticity. Say, for example, we at 60, you want to learn the violin, please do so. You want to learn swimming at 70, no problem, please do it. It improves. So, for example, there are now Japanese researchers who are making people do Sudoku or crosswords and have shown that actually over course of time, their degeneration in terms of memory is very less compared to people who don't do that. And also involved reading. When I say involved reading, it is something that you have to forget yourself. So all these activities, yoga, for example, you have to forget yourself and focus on what is happening. That involvement is what makes it different. And this Dr. Gangadhar also showed yesterday that when people, particularly yoga and meditation over a long period of time, they lose less gray matter than people who don't. This is another one in female elderly yoginis. They have called them yoginis who have done for a long period of time. That area, as you can see in red, is much, what do you say, bigger than people who do not. This is something we did in Enhance. We were able to show an actual increase in the size of the hippocampus after 6 months of yoga in normal, healthy people. Healthy, when I say, they are elderly people who have slight difficulties in memory. And over 6 months of yoga, they were actually able to change their brain in a small way. When we come to yoga, of course, a lot of words have been said about this, but I would like just to point out here that the Bhagavad Gita defines yoga as Samatvam Yoga Uchyate. And when the Nimhan's logo was made by Professor Govinda Swami, the first director in 1954, he thought that was important enough to put it in the logo of Nimhan's itself, as you can see on the picture. And yoga gives a very simple template for optimal health. So, yuktahara viharasya yukta chestasya karmasu yukta swapnava bodhasya yogo bhavati dukkha. So, everything has to have moderation, like your glucose control, where people were talking in the morning. Controlling it too tightly is a problem. Not controlling is a problem. You have to have a place where it can move here and there. Variability is the essence of life. But everything has to be in the moderate category. And when people talk about yoga, like I said, they forget about all these other aspects. As Indranil Basure was saying, in America, yoga essentially means asana or cardiac exercise. But these are really Ashtanga yoga. And in fact, if you do yoga the way it is supposed to be done, many things are the exact opposite of what we generally consider as exercise. You run on a treadmill, what happens, and you do yoga, it's actually, many things are actually opposite. Physiologists like Dr. Lina Padke, I'm sure, will agree. And this is a slide I put in all my presentations, just to show that how you do something is as important as what you do, because the position looks very similar. The effects the next day morning are likely to be opposite. So, of course, the person on the top is the Guruji for all of us, and the person on the bottom, I don't know, but I hope he's okay. So this I don't really want to focus much, but a lot of work has been done on yoga in healthy populations, showing multifaceted benefits, including all the way from mild depression, anxiety, all the way to increase in cerebral gray matter. But importantly, I want to show what has been done in Enhance in terms of major research findings in people with mental health issues. So these are the main, what we have been doing over the last 15 years in the yoga center at Enhance. So two aspects. One is, of course, improvement in symptoms, whether it is depression, schizophrenia, memory in the elderly, alcohol dependence, and other psychiatric disorders. We have been able to show improvement in some symptoms. But the important point is that we also have been able to show possible mediators or correlates in terms of the biology. It could be cortisol and BDNF in depression, oxytocin and mirror neuron activity in schizophrenia, increase in hippocampal gray matter volume in cognitive impairment, decrease in cortisol and ACTH in alcohol dependence. This is what we have been doing at Enhance. Of course, other psychiatric disorders, a lot of work has still to be done. I was just talking to Dr. Fatke about autonomic nervous system and GAD, anxiety disorders. I'm sure there is, but nobody has actually done it. So something has to be done there. So finally, let's come to the very interesting question of how these things happen. As you know, we learn yoga by imitation, learning from the guru, whether it is YouTube or it is Iyengar Guruji, some guru has to be there. Learning from a book is not the recommended way. Neither is YouTube, but it's an acceptable substitute in COVID era. When you imitate and perform them in mindfulness, your mirror neurons become active. And that's the way that it seems to work. Then you synchronize the breath with the moment. You learn to remain physically relaxed within the posture. Stiram Sukham Asanam is very difficult to do. If you ask me to do Surya Namaskar very fast, it's very easy for me. Everybody can do it. You ask me to do it very slowly, hold each position for 10 breaths. It's very difficult. We will start trembling. We will start sweating. Renard, I remember Bogleshwar, we started trembling just holding a simple post with the wall. Holding it is very difficult. That is what we have to learn. Focus on the experience and then add the pranayama part. As far as the effects are concerned, there is a lot of work which has been done, which I'm already experts have spoken about. So I'm not going into this. These are all physical things. I'm going to focus on what we did, as Dr. Gangadhar said yesterday. Reduction in cortisol in patients with depression. In those who did yoga, depression did get better in people who took antidepressants. Yes. But did the cortisol go down? Not so much. So why is this important? Now, at the end of 6 months, patient comes and says, I'm no longer depressed. Can you take me off the medicine? The first question I ask is, okay, what changes you have done in your life in the last 6 months? If you have done something to change your lifestyle, you have picked up a hobby, you have picked up some passion, you are doing yoga, you are doing cycling, okay, then there is a chance. Otherwise, very likely that the depression is going to come back. Or as something has changed in your life, your marriage has got better, your financial situation has got better. If none of this have happened, 99% the depression is going to come back. Whereas if you pick up yoga as a lifestyle, this may not happen. That's what it's indicating, that the stress, which is the base for all the depression, gets better with yoga. And very nice correlation between the depression going down and the cortisol going down shows that the two are interlinked. And next comes this molecule, which many people see as the marker of this neuroplasticity, the ability of the brain to rewire itself. And this, there is a process by which pro-BDNF becomes mature BDNF. And this process is actually stuck in depression, patients with depression. Recently, we have not yet published it, but my PhD student Aditi did this work showing that in patients with depression, this process has got stuck. And after yoga, this process happens better. So depressed people who do yoga, the serum BDNF increases towards normalcy. Within a month, we have been able to show this. And, this is something that, again, somebody was asking the question yesterday, okay, 6 months later, I stopped doing yoga. Of course, most of the changes are going to go away. You need to wrap this as a lifestyle. Again, a very nice correlation between cortisol going down, BDNF going up. So cortisol seems to reduce this BDNF, you reduce neuroplasticity. Increased cortisol is a sure sign of stress. Similarly, in schizophrenia, there is a neurohormone called oxytocin, which people call as the bonding hormone or the love hormone. Again, it is low in patients with schizophrenia, and after yoga, it improves. How does it improve? This is from my unpublished data from my current ongoing Welcome DBT study, where we are able to show that gene expression of oxytocin increased within 3 months of yoga practice. Another aspect is cortical inhibition, which is mediated by GABA, GABA-aminobutyric acid. Again, this Dr. Gangadhar explained yesterday, so I'm not going to go into details, but yoga improved this ability to inhibit. Somebody, I think, was asking today, Dr. Sarita, I think, why women are more depressed than men. One of the main theories is that women ruminate. Women tend to ruminate much more than men. Men tend to externalize. They may drink, they may hit somebody else, they may something, but they don't ruminate so much. Women keep it inside and ruminate, and that's one of the factors which Martin Seligman says is that why women have a 2:1 chance of getting depressed more than men. So cortical inhibition is the ability to inhibit things that you do not want, stop things that are going on that you do not want. OCD, for example, this is again the big problem. So briefly, let me talk about the mirror neurons. I have around 3 minutes left. So mirror neurons are a very interesting group of neurons that get activated. Professor Rizzolatti showed that this get activated when you see somebody doing an action. You don't need to do that action. So I do this and you see me doing it. Some neurons in your brain get activated by this. You don't do that, but then they get activated. And both mirror neurons and oxytocin are low mirror neuron activity. MNA means mirror neuron activity. Patients with schizophrenia, that is why they have the deficit in empathy or social cognition. So a child is crying, all of us feel sad. I don't know why the child is crying. Child is not mine. I don't know it, but I get. How do we do that? Our mirror neurons tell us what is going on in the child's brain. This ability is reduced in autism and schizophrenia. So they cannot pick up the emotions of other people, and that is what makes them socially deficient. My wife is not happy with me if I can't even make out. Where is the question of me doing something about it? So that is what happens, and there is a very clear connection between these mirror neuron deficits and social cognition and empathy. And this is where yoga comes in. Oxytocin is elevated by yoga, and so is this is the way that we do mirror neurons. It's a FNIRS is a very simple instrument, again ambulatory, which is coming into a lot of. I call it the poor man's MRI, because it only can show the top 2 or 3 mm of the brain, but it can show changes, and you can do it. You can wear the cap and do the yoga or do meditation or whatever it is. You don't have to go inside a gantry. And in a small group, we were able to show that actually there is enhancement in the premotor cortex. This is the area before and after the yoga. FNARS was able to pick up the change in mirror neuron activity. So this is what people talk about. When you ask people, Gangadhar has a very example of a person who came and say, I feel connected now to the society after I did yoga. This is this because of mirror neurons is a very likely possibility. And this is what Dr. Gangadhar was talking about. What happens when people with schizophrenia do yoga? The network coherence actually increases. So madam was asking about mind wandering. So these people have extraordinarily high mind wandering, and this seems to come into control after doing yoga. And actually what has been shown to improve in schizophrenia, not so much the hallucinations and delusions. We have very good medicines to treat those, but we don't have medicines for the cognitive problems and the negative symptoms of schizophrenia, which is where yoga seems to work. And this is possible mechanisms that we have developed. So to conclude, I would say that, positive mental health is a matter of training and strengthening selected brain networks. Luckily for all of us, the brain is an excellent trainee. That means neuroplasticity is possible in all of us, whether we are 16 or we are 60. Doesn't matter. To tell you a point, there has been recent research to show that in the hippocampus, in the olfactory area, new neurogenesis happens even at the age of 70. So there are only 2 areas in the brain where this goes on till late. And yoga is simply one of the most systematic methods of training the body and the brain. There is a very beautiful book called Flow. I mean, many of you might have read it, in which the author, is one of the positive psychology pioneers, actually. His name is very difficult to pronounce. He's also famous for that. Csikszentmihalyi. Csikszentmihalyi is his name. He's a Hungarian who emigrated to the US during the Second World War. This is taken from his book, Flow. He says, there are many methods of training the body. Yoga is the best, and West has not been able to come up with anything like that in the past 5,000 years. That's what he has said there. What are the implications for endocrinology? As we all know, most of the endocrinological disorders are also now likely to be found to be brain disorders. And yoga practice has salutary effects on brain health. Most importantly, the feeling of well-being. When I met Dr. Vaishali the first time, she told me, when a patient comes back with a normal TSH, and I am telling the patient your thyroid is normal, the patient is telling me, but I am not feeling well. So what do we do? That's where the yoga comes. Most people, when you ask them, why do you do yoga? They say, I feel a bit better. I feel well after doing yoga. And that is the most important thing for a patient. Of course, we also have to do a lot of research on how this happens. Some of it we have already done. A lot of it needs to be done. But this has huge implications for most NCDs, as Dr. Sartorius was saying. We need to look at NCDs as a whole. I'd like to acknowledge the collaborators, and most importantly, our guru, Professor Gangadhar, Dr. D. Nagaraj at NIMANS, who have worked with me, Dr. Venkat, who is the master. Actually, I am not the person who does most of the imaging analysis. Is Dr. Venkat and Dr. Bharat. And of course, we have a good team at NIMANS. I would like to thank Dr. Vaishali, Dr. Fadke, and all the people who invited me here. Thank you very much.
Thank you, Dr. Shivrama, for a wonderful lecture and for talking about newer concepts in neuroplasticity, the link between yoga and mirror neurons, intermittent fasting as a way to exercise the brain. It was a very fascinating lecture. And now let's hear from Dr. KVS Harikumar, who's the next speaker. He requires no introduction. He's a secretary of the Endocrine Society of India, very eminent endocrinologist himself, a close friend, has worked in various institutions, has a very strong research interest and an ability to publish top class papers. And he's going to talk to us about case studies in psychoneuroimmunoendocrinology. We welcome Dr. KVS Harikumar, a consultant endocrinologist at the Magna Clinics, Hyderabad, has several awards and orations and more than 200 index publications with very high scores in such as the H index. Over to you, Dr. Harikumar.
Good afternoon, sir. Thanks for the kind words. And good afternoon, everybody. Good afternoon, ma'am. And thanks inviting us to be part of the Synapse 2022. It's always a pleasure to be part of this and learning something new about what we generally don't discuss in the practice. So I hope I am audible and my slides are visible.
Yes, of course.
So I will just speak. I mean, seeing the research as what Dr. Shivram has said, we don't, come closer to it, but at least some start with our reports. I'll just share in the next 10 to 15 minutes how this field as such has impacted us or possibly helped us in understanding some of the things. I will just give a one slide introduction, 3 interesting reports, 3 studies, 3 review articles, and 3 lessons from all this in the next 15 minutes. And the images onto your right, you actually see the person who has a Hungarian-born Canadian worked endocrinologist, Professor Hans Selle, who actually gave the term as stress, de-stress, eustress, and actually looked at how best the stress and endocrine links have been established. This was the era when possibly the cortisol was not even yet identified, but he was the one who could lay foundation about all that HPA axis work and linking up the stress with the endocrine system. So it's a tribute to him. So the positive thoughts, emotions, and everything actually enhance the health. I mean, we all explain that, we all maybe give that bit of information, but that is possibly lacking in much in the clinical improvement. And this would actually help in maybe that nature assisted response, or maybe getting over the placebo, more than the placebo, what would actually happen. And all of this is mediated by the hormones. So some of it is integrated in the management of the NCDs, especially if you look at all these behavioral therapies, music, relaxation, everything actually tries to give you some perspective about modifying your health in other way rather than only with the medicines. And the disorders, what actually you can get improvement is any of these stress, IBS, chronic pains, ADHD, sleep disorders, even diabetes, cancer. There are a whole host of disorders which have an implication, which have an interest in this field. Unfortunately, at some point of time during our training or some other, we are more emphasis is on the physical rather than the psychological aspects. So that is where we are possibly losing out this benefit. And maybe we have not much of time in the practice to listen to the patient's complaint, or maybe put them all in one basket and then have analysis properly. So possibly neglected because of overburden in the clinical practice also is one aspect of it. So we'll go to the first case. 29-year-old male, absolutely no previous ailments, married, but could not perform sexual performance up to the satisfaction. So with this background, without any other thing, he consulted a practitioner initially, who said, okay, you are unable to do, so it is, you are got some problem, so go to a psychiatrist. Now this guy, when he is referred to a psychiatrist, obviously is in a low mood because of his marital discord and other issues, complained about that, and he will obviously fit into a criteria of DSM and diagnosed as a moderate depressive disorder. Now he was started on fluoxetines, not improved, dose escalated, another group changed, not improved, did some ECT sessions, about 4 sessions, not much of improvement. And his complaint was always the same, that his libido is reduced and is unable to perform. Now, at this point of time, after about 6 months of therapy from the initial day, then the psychiatrist referred to us saying, okay, for this you also see an endocrinologist. Now, the other relevant history was reduced frequency of shaving and normal. Other rest of entire physical systemic examination was normal. Looked at his basic profile, HbO slightly on the lower side, normocytic, normochromic, prolactin, thyroid, basal cortisol was normal, normal LH-FSH with a low testo, and a repeat testo also was low. And you can see the image onto your right side, which shows an empty cella. And we did a ITT, which showed a normal stimulated cortisol and GH. So by and large, this patient actually had a hypo due to a primary empty cella without any issue, but actually being treated as a moderate depressive disorder. And his complaint was a physical of the poor sexual performance. The second patient, 37-year-old lady, housewife, diagnosed as a case of seizure disorder almost about 2 decades back. Always had breakthrough seizures all throughout. There was never respite from her seizures. And because of recurrent seizures, she would feel more anxious, more paresthesia, and because of long-term usage of anti-epileptic, she was on reasonable doses of vitamin D's and calciums, but not much of improvement. So because of persisting paresthesia, and she was referred to us by the neurologist. And the moment you started inflating the BP cuff, you don't even have to wait 45 seconds. The entire trousers will come positive. And initial MRI done was normal. So possibly they have not bothered to repeat an imaging. They was always saying initial imaging was normal, so persisting seizure, so breakthrough seizure. And this was a repeat CT we did, and calcium profile, phosphorus elevated, vitamin D normal, low PTH, a typical case with bilateral basal ganglia calcification, and which is basically a idiopathic hypopara, always being treated as a case of seizure disorder with anxiety attacks. So we published this in 2012, 2 cases highlighting the psychoneuroendocrinology as a specialty, which was not picked up, or which was rather picked up very late. Some guy after about a year, and another lady almost after a decade delay. Third, luckily in this patient, we never had that much delay. We were involved only because of their hypersexual behavior, because of maybe blaming it on testosterone, young adult having hypersexual behavior. But there were some other features which suggest that there was underlying physical ailment. So there was not much of delay in these patients. These are secondary to measles, and secondary to measles, which leading to subacute sclerosing panencephalitis, SSPE presenting as a hypersexual behavior. So these are the 3 different psychiatric overt manifestations which have underlying maybe a physical disease or an endocrine disease, which is important whenever we look at in managing these patients. Coming to 3 studies, the first and foremost and the most important, I would say, is the amount of research productivity about psychosocial aspects of diabetes. We just did a PubMed based, what are the number of studies which are there. Out of 1862 records, only 16 were concerning the psychosocial aspects of diabetes from India. So look at the percentage, 0.008% only, as far as the entire, I'm talking about not only diabetes, it is psychosocial diabetes across the world, and only 0.008% from India. So there is a huge gap which is there. 2 interesting related ones, what we did about the attitude of healthcare professionals. We used a diabetes attitude scale by University of Michigan. Interesting thing, we did it from the medical postgraduates and nursing students in our institute, and despite in the same background or maybe working in the same hospital, the duration of residency, as their higher duration, their seriousness about diabetes improve. So it's, heartening to know that the education actually helped them in understanding the disease more, or possibly they are learning it more, or maybe seeing the more complications, be it both the medical as well as nursing students. another thing improved with the age, another thing improved with the duration of residency. So the more possibly awareness, more exposure to the disease would actually help them in understanding the implications of this, and they are more serious about the disease later on. How about the patients? The diabetes empowerment scale, again, almost somewhat similar phenomena, I can say. The older age group, not the younger age group, are feel that they are more empowered. Possibly the older age patients have longer duration of diabetes, so they feel that they are more empowered. They can take the decisions, they can change the disease, and possibly the goal setting. All these aspects, the older age patients and the persons who have longer duration of diabetes are the ones who actually were scoring more than the younger patients than the recent onset diabetes. We all know about the Barker's hypothesis and low birth weight and adult disorders. But we all live in the country where resource poor country, so we should be looking some of the options in the management to these people who are more, I would say, at a disadvantageous position, because I'm sure many of you also would agree that there are very many number of patients who take medicines, who take insulin alternate day because they just can't afford it to take daily basis. So some of these things propagate, or maybe we need to devise certain things, explain to them, and lack of education, because they are the ones where it is actually becoming more as a burden in the society, because by virtue of being in this part of the world, their genetic risk remains the same. So we need to maybe devise certain strategies how best to tackle diabetes in such scenarios. Sleep hygiene and diabetes, lack of sleep is being propagated to across very many number of NCDs, and you have a different mechanisms which can contribute. This was a review which we published a few years back. You can see the hormonal changes, you can see the neurological changes, you can see the immunological changes. All of them are interlinked, and lack of sleep will propagate your most of the NCDs, at least your obesity, diabetes, hypertension, to some extent the cancers also. So it is important to have good sleep quality and quantity to prevent or reverse this worsening. The ominous octet of diabetes we all know, but ominous octet of non-communicable diseases, we put this big S for everything, right from your sexual differences, sexual preferences, the consumption of salt, sugar, sleep, we've already discussed, smoking, the stress, the entire conference is of the same thing, adequate sunlight, and not having the sedentary behavior. All these factors are actually important in day-to-day life, and educating about the patient, and maybe taking their inputs and taking their suggestions and give them the tidbits about how best to change and get that extra benefit, rather than with only the tablet what we are going to prescribe. So it's important to educate them at every point of their interaction. Every touch point we should be highlighting some of them as a routine lead to these patients for improving the outcomes in the management. So the three lessons what we learned of all this from the cases, it is number one, the detailed workup. The teaching is always that you should rule out the medical ailment before blaming somebody that it is psychological, especially in a fields where we have overlap symptoms. So it's always important to educate the students about look in detail, spend some extra time as to actually, I mean, the first patient was actually an eye opener, because when you have when a common garden, normal young looking male coming to you with low sexual performance, there is no reason for you to refer to any psychiatrist. But unfortunately it has happened because possibly the symptom was considered more of a psychological rather than a physical one. So it's important to educate and maybe spend some more time in the history and look at the entire perspective in which he has come. That would maybe give us more benefits. Studies, the scope of work, as I've said, it's minuscule in the comparison. There is enough scope actually in this field which has not been explored much. You have n number of aspects about the patient centered or maybe behavioral aspects which we all can do enough research on, maybe look at how best the Indian patients differ, or maybe from when compared with the West, how the outcomes are different, perspectives, all those things we can actually look at conducting very many number of studies. Integrating this into the practice, it is not only the medicine, there is some social aspect to the medicine also is important, and giving back to the community, to the society, to the patient who is sitting, rather than only the medicine, always helps. Focus on NCDs, no less. And the last decade is the first decade since the existence where the prevalence of obesity has crossed the prevalence of malnutrition. So we have to be very much focusing on the NCDs. There is no getting away, and possibly look at more collaborations, more multicentric studies. That is what is going to help and put everybody in a common platform. So to conclude, I would say that this is the famous Ubuntu philosophy. I am because we are. So we should be looking at ways and means of collating data, collating systems, processes, and then maybe put these things for betterment of our patients. I've finished here. I'll be happy to take any questions or comments.
Thank you, Dr. Hari Kumar. I'm told that questions will be at the end of the session, but thank you for a wonderful, crisp presentation of cases, important publications, and clinical messages. And thank you for highlighting the importance of psychosocial research in people with diabetes. Thank you for that presentation. And now we have another giant in the field of endocrinology from India, Dr. Rishi Shukla. Sir is going to speak to us about mind-body medicine in type 1 diabetes. Dr. Rishi Shukla, may we have his CV, but requires no introduction to the endocrinologists of the country, because he has been one of the most senior endocrinologists and practices in Kanpur. He has a special interest in type 1 diabetes. When I say special interest in type 1 diabetes, he has a huge patient support group, programs, and programs which are aimed at benefiting people with type 1 diabetes, testing, monitoring, insulin, special programs for them for training, as well as bringing them together as community support groups. It'll be wonderful listening to you, sir. Once again, welcome virtually, and looking forward to your presentation. The online and the hybrid podium is all yours.
Thank you, Dr. Unney. My slides are visible?
Yes, sir.
All right. Thank you, Dr. Unney, and it was pleasure listening Hari Kumar. And it was a double pleasure listening Hari Kumar, because he spoke totally on his own work. Thank you, Hari. I mean, I knew you are a genius, but I could understand you are super genius. And before I start, a big thanks to Dr. Vaishali, because she has now started playing the mind game. So from spiritual angle, from yoga angle, we know the mind is the driver. And if we can go beyond mind, I think we have done. So I'll be discussing about meditation and diabetes. And what is meditation? It is practiced since ancient times, because we have been talking about 5,000 years or so. With the earliest reference going back to Vedas, it has formed an integral part of Eastern religions, including Hinduism, Buddhism, Jainism, and Sikhism. Actually, these are all religions which are basically enrooted from the Hinduism. So yoga and meditation are part of the same. What are its effects? It is associated with a greater voluntary control of mind and emotions, and cultivation of positive mental attributes such as calmness, serenity, concentration, joy, and love. It is also associated with reduction of anxiety, depression, anger, fear, and hatred. So if you look at joy and love, see all those hormones, oxytocin and endorphins, we have been discussing for the last 2 days. What is the logic? To my understanding, all these activities are associated with increased level of serotonin, dopamine, and endorphins. And all these three have some suppressive effect at the level of hypothalamic pituitary adrenal axis. And this helps in blood sugar control also. What is the role?
Sorry?
Meditation, yes. Meditation-based therapies were associated with significant improvement in blood pressure, glycemic control, body weight, and waist circumstances. What are the disadvantages? Because nothing is without this. We have to pay the cost. So those who are totally into it, they have more emotional pain, empathy. The topic is mind health of patients with type 1 diabetes. And I'm going to speak basically on meditation. I have some work, and before that, we have been talking, but I tried to review the literature and understand what meditation is. It is practiced since ancient times, with the earliest reference going back to Vedas, and it has formed an integral part of Eastern religions, including Hinduism, Buddhism, Jainism, and Sikhism. All these four religions are basically rooting to the Hinduism. And what are its effects? It is associated with greater voluntary control of mind and emotions and cultivation of positive mental attributes such as calmness, serenity, concentration, joy, and love. It is also associated with reduction of anxiety, depression, anger, fear, and hatred. So we've been talking about anxiety, depression for the last 1.5 days. What is the logic? All these activities are associated with increased levels of serotonin, dopamine, endorphins, which then lead to suppression. These hormones have some suppressive effect at the level of hypothalamic pituitary axis. So cortisol and other stress hormones are reduced. And this indirectly helps in blood sugar control. What is its role? Meditation-based therapies were associated with significant improvement in blood pressure, glycemic control, body weight, and waist circumference. It is not free of disadvantages because it leads to emotional pain, a lot of empathy you develop, because once you are into it, you are likely to change. And as I was talking to Dr. Hari Kumar, here you become the driver instead of your mind. So you have more emotional pain, more self-criticism, whatever good or bad you do, you don't justify, you feel you're doing it. Lack of motivation is another negative factor. Now enough is enough, I don't want to do more. Sometimes insomnia or lacking something. But these effects are mild and transitory and did not lead to discontinuation of meditation. This may be part of psychotherapeutic effect. So once you do it, initially there might be these things, but vairagya type of thing or whatever word you use it. Coming to type 1 diabetes and stress, they are at increased risk of psychological stress due to underlying disease. Stress also increases due to complexities involved in treatment. The psychological aspect of diabetes, this is both type 1 and type 2. They are important as managing the medical part of diabetes. The barriers are twofold. Treating clinician does not have time, and patient and family are focused only on medical management. They are not aware about psychosexual aspect. Because to my understanding, what people talk about, those who touch the psychological aspect, who touch the man of a patient, they say doctor is good, that's it. But they don't understand that there is a huge psychological part. And in most of the clinics in our country, this part is not touched. And the fact is here, we are also very, very busy. We are not able to finish our own routine work. So the psychology part, I think it's at times tough to handle. What is its value? It is tough for the patient and family to accept that they need insulin for whole life, for type 1 diabetes especially. And this thought gives distress and anxiety, which eventually leads to poor self-care. Poor adherence and self-care leading to deteriorating metabolic control, which further aggravates distress, anxiety, or even depression. And we are needed to break this cycle. The impact of social issues are of twofold. The social issues itself leads to fluctuation in blood sugar and overall control. Social circumstances also lead to distress and depression. I think many of you remember RSSDI 2015. Professor Ish Bhatia, he is head of the department of SGPGI in Lucknow. He's also very passionate, and I learned about my passion from type 1 diabetes from him. He's my teacher that way. I worked for some time at SDPGI. And what he said, I invited him as a chief guest in that meeting. And what he said, life of type 1 diabetes is not easy. They have to make huge efforts to sustain themselves. Actually, in that meeting, if you see a lot of faces of diabetology, Dr. Deepak Dalal, Dr. Archana Chalda, Dr. Sunil Gupta, Dr. Madhukar, is Dr. Ganguly, our local eminent person. And his Larry Hirsch, he's a BD global chief. He himself is a type 1 diabetes for last 50 years. So end of the RSSDI meeting, we had this huge patients program for type 1 diabetes exclusively. All of stress in type 1 diabetes, it is divided in two parts. One is the positive stress. Stress is important because it leads to motivation and appropriate action. Because I was stressed in this afternoon because I was supposed to speak. After lunch, I slept. But negative stress and distress can have significant effect on neuroendocrine, cardiovascular, and immune system, and central and nervous system as well. What are the non-medical modalities of type 1 diabetes treatment? The diet, the physical activity, stress management are well-known modalities to manage, but we talk these two. We seldom talk. Dr. Hari and Dr. Unni, my other panelists and the friends would agree that stress management, we talk seldom. Coming to meditation and type 1 diabetes, it has a known role in type 2 diabetes, not a known modality in type 1 diabetes. There are no researches available on meditation in type 1 diabetes. Very recently, I have a paper on medical sciences, the mindfulness meditation as adjunctive therapy to improve the glycemic care and quality of life in patients with type 1 diabetes. And it was supported by my younger colleague, Dr. Manisha Neha, and my colleague, Dr. Anurag Vajpayee. Our understanding is that mindful meditation should reduce HbA1c and quality of life, as I shared with you. And what this study is, we had total 32 people, 15 males and remaining female, and it was a 6 months trial. The inclusion criteria was very simple: type 1 diabetes, aged 18 to 50 years. No HbA1c criteria we kept, but exclusion criteria was proliferative retinopathy was ruled out, nephropathy, established coronary artery disease, pregnancy. This is the patient profile. We divided 16 patients of two groups. Age is matching if you look, duration of diabetes is almost matching, weight matching, blood pressure, BMI almost matching, hemoglobin matching, creatinine, SGPT, TSH, A1C in the both arm were 9.3 and 9.1. Urine albumin creatinine ratio was all right. And what we did, we divided patients into two groups, intervention and control. Intervention group was properly educated about mindful meditation by a skilled coach. They were received to practice mindful meditation 20 minutes daily. Compliance and adherence was followed by a weekly telephonic calls. And once a month in person, we invited all of them once a month and we did a physical meditation under guidance. We also developed an app that was supplied to them and they did meditation with app as well. And what was the procedure? It was combination of breathing exercise and mindful meditation. And what was it? All subjects were asked to sit comfortably with spine straight. And we divided into 6 steps. Step 1, first 6 steps are breathing and another 3 are mindful meditation. The step 1, asked to inhale and exhale as deep as they could for 6 times. Then step 2, asked to inhale while mentally counting up to 6, then hold up to 6 and then exhale. And this procedure was done again for 6 times. Step 3, the third breathing component, asked to do rapid inhalation and exhalations for 6 times. Now coming to step 4, that is mindful meditation, they were asked to visualize their thoughts without entertaining the thoughts for 2 minutes. Like you visualize what thoughts are coming in your mind, but you don't entertain. I'm thinking of Dr. Hari Kumar, but let Dr. Hari Kumar washed out. Step 5, visualize, breathe, and feel that each inhale peace is coming and is gradually increasing. And when actually what happened by the end of step 5, the peace level increased. And in step 6, sit quietly for 10 minutes. This was a total procedure and it required around 20 minutes of duration. And they were asked to do every day in their home. The quality of life and distress scores, if you look this paper, this is before intervention and after intervention. So economic burden wise, there was some difference. We did different things: the physician related distress, regime related distress, interpersonal distress, total diabetes distress. And if you look at total diabetes distress score, it was a significant difference. The distress was lesser after intervention in the intervention group compared to control group. Then quality of life, we did health and functioning. There are different domains in which we work: social and economic, psychological, spiritual, family, total quality of. So we did not find much difference. So distress was significantly different. We also looked at BMI. We did not find a significant difference in BMI, systolic, diastolic blood pressure, HbA1c. If you look here, clear cut, this is the intervention group before and this is the intervention group later. So thanks to my colleague Dr. Anurag, who was categorical that we should have control. Had there been not control group, we could have said that it played a significant role, but we had a control. So control also came out with the same, because we put AGP. So by putting AGP in both these two groups, which has not mentioned, a significant difference has been mentioned, which is mentioned in the literature. Mean blood glucose wise also, there was a difference, but again, if you compare to control, there was no difference. So mindful meditation in type 1 diabetes has significant effect in diabetes distress. Type 1 diabetes, way forward. Life with type 1 diabetes is full with challenges. The problem is real, but we can handle them nicely. I always say you have a problem, but it is the problem that we can handle. It is not cancer that you going to die in 6 months or years or so. And the game changer is mind that we have been talking. If we can handle the mind, or we can learn them to handle mind, and so mindfulness meditation helps in balancing the mind. In a nutshell, mindful meditation is a new area as adjunct to lifestyle changes type 1. We never talked, and for the first time, I think I could prove in black and white that it has some role in management of type 1 diabetes. This area has not been explored in type 1 diabetes, and this is first worldwide work on type 1 diabetes and mindful meditation. This is my entire staff, and Dr. Sangeeta with me, she is ophthalmologist, my wife. Dr. Manisha, she has contributed a lot, and she is the study coordinator, Mrs. Meena. This is my entire team with whom I've been working. And greetings from Society for Prevention and Awareness of Diabetes. We've been doing regular, uninterrupted education program on every 4th Sunday, like we had today. And this is a team which comprises of doctor and the patients from society, and we have been going on. And evening, this is a place nearby where I walk in the evening. Summers are on, so I thought this is beautiful, and I thought of sharing. And thank you so much for your kind attention. Thank you, Dr. Oni. Thank you, Dr. Harikumar. Thank you, Dr. Vaishali. Thank you so much. I think I finished on time. Yes, Beena, nice meeting.
Thank you, sir, for that inspirational talk and for highlighting the important work you do and your important insights in type 1 diabetes management. We'll have questions at the end of the session, and the next speaker is Dr. Beena Bansal. She's again a very well-known and senior endocrinologist from Delhi. May we have the CV of Dr. Beena Bansal, please? So, Dr. Beena Bansal is a founder and director of Door to Care and Endocrine Diabetes Clinic in Gurgaon. She is the president of Saksham, a type 1 diabetes welfare society, has interest in hypocalcemic cardiomyopathy, PCOS, gestational diabetes. Uh, she's also interested in developing areas of interest regarding narrative medicine, medicine humanities, behavioral sciences, and chronic care medicine. And recently, she conducted a very important conference which discussed the importance of humanities in clinical practice. Uh, Dr. Bansal is uh, known for being a wonderful speaker. I've heard her speak, very clinical, very practical, and very lucid in her presentations. And Dr. Bansal is going to speak to us about the importance of narrative medicine in endocrine practice. Over to you, Dr. Beena Bansal. Welcome.
Thank you, Dr. Vaishali, for having me here. And it was inspiring to listen to all the previous talks here. I'll start my presentation quickly. That's okay. Yeah. So are the slides visible?
Yes, yes.
So I will try and summarize narrative medicine in endocrinology. I'll see how precisely I place it in context of endocrinology. So narrative medicine in general, and also, of course, in endocrinology. Yeah. So stories are important. We know that. In fact, stories are important for survival, and that she's a very favorite author who says that we tell stories in order to live. I think that makes sense, not just for authors, for all of us. Stories are what makes our life. So each of us constructs and lives a narrative, and this narrative is us. This is by famous neurologist Oliver Sacks. And we'll realize that a lot of older endocrinologists, neurologists who have been practicing medicine, who laid down the foundations, people who described various syndromes like Cushing syndrome, etc., the way they narrated the stories of patients has been the basis of what we understand today so much about medicine. Stories are important because they are part of our personal identity. So personal identity is the internalized and evolving life story that each of us is working on as we move through our adult lives. So we try to construct a coherent story in our lives, and that's really core to our survival. So it's important to understand this aspect before we move on to narrative medicine. I do not know who I am until I have a good understanding of my narrative identity. So this was by Mac Adams. He is a social psychologist. What is the role of stories in medicine? It's nothing new. Stories are always told in medicine. Patients tell their stories about a symptom or concern and how it affects them, why they have come to the doctor. The stories are always there. So narrative pretext is always there. Narrative medicine is not something new. Only thing is now we are trying to formalize that as under narrative-based medicine. Doctors also bring their own stories to the consultation. When we hear or listen to patient stories, it is always through the lens of our own reflection. So our stories play an important part in patient stories, and that is very important to understand because empathy is important, but it's not an easy job to do. Understanding what the other person is feeling is, I think, next to impossible because we do not live their lives. We can only reflect on their problems through our understanding. So whenever we are listening to a person, I think that's an important thing to remember. The doctor's understanding of what is occurring to the patient. We tell stories further on. We formulate a diagnosis. We formulate an idea about cause and management, and then how to communicate to the patient. That also is a part of storytelling. So doctors also need to learn some part of storytelling because that is how the patient is going to make sense of what you are saying. So stories are important in medicine. But what is narrative-based medicine? People have been trying to define this. I'll just put forward different definitions which people have forwarded. So Rita Sharon, she was one of the early proponents of narrative-based medicine, and simply she defined it as to recognize, absorb, interpret, and be moved by the stories of illness. So when I say illness, later on I'll come to that, there is a difference between disease and illness. So in social sciences, disease and illness have a separate entity. Disease is what doctors, we define as a medical diagnosis. Illness is what is perceived by the patient. So in 2014, a forum came together on which discussed what is narrative-based medicine, and they summarized it as a fundamental tool to acquire, comprehend, and integrate the different points of view of all the participants having a role in the illness experience. So narrative-based medicine involves taking point of view of the patient, of the caregivers, of the doctors, and integrating it all together. That's important. So the fundamental tenet of narrative-based medicine is that meaning is derived from the stories that we tell. So putting it all together, so narrative-based medicine is about storytelling, basically, the patient's story primarily, but also the doctor's story, and importantly, how these stories interweave in the clinical encounter. So these are not two different stories coming and colliding together. They have to interweave and create a new story with new meaning and understanding and the possibilities of change. This also involves acknowledging the uniqueness of each patient, because then only we can validate his or her story. Every story is different. We can't have a pre-formulated idea that this patient will fit into this criteria. Every patient has a unique story, and therefore it needs a genuine interest and concern in each patient's story to go ahead and form a unique bond with the patient. It also helps in recognizing the divide that exists between doctors and patient. And we have been lately recognizing this more and more, that there is a divide, and there are steps which need to be taken to bridge this divide by developing and strengthening connections. It's not easy to listen closely. There are issues with that. There are critiques of narrative-based medicine because getting too involved in patient stories has its own issues. The time it requires, exploring fears, feelings, emotion. One, this needs an art. It's not trained. And second, it may divert us from what is clinically important. That's a concern in most people's mind. So that's something which we will discuss. So why do we need narrative-based medicine? As we said, there is a divide between doctors and patients, although as in this forum and in various forums now, even in our medical curriculum, there is a lot of importance given to good communication skills. We are trained by most corporate hospitals. There are trainings done on good communication skills, how to dress, how to present in front of the patient. There is a lot of discussion on patient-centeredness, that we have to give patient-centered care. There is an increased understanding going beyond biomechanical concept of disease, going to biopsychosocial and holistic paradigms. And there is a focus on addressing patients' ideas, concerns, and expectations. Despite all of this, patients frequently complain that doctors do not listen. What do they mean by that? There is still a feeling that they appear disinterested, they interrupt, they make assumptions. These are data collected from most patients, and there is a difference between what we think we are doing and what patients think we are doing. Doctors defend themselves by saying that there are difficult patients, of course, and the pressures of patient numbers, time, and of course, it's not easy in today's day to practice that kind of medicine, which I think maybe 1 or 2 generations back, that connect between patient and doctor is becoming more and more complex because of complex system of delivery of care and the travesty of consumer medicine. So narrative-based medicine seeks to redress some part of that imbalance. So as I mentioned, Rita Sharon, who's a proponent of narrative, says that while doctors might be knowledgeable about disease, they do not appreciate adequately that illness changes everything for the patient. So she has divided the disconnect into 4 divides. The first is the relation to mortality. So for patients in our endocrine setting, I'll try and put some examples here. Most patients suddenly who are diagnosed with illness, they come with diabetes, there is suddenly a fear of death. The illness elicits many emotions. Patients' attitudes towards illness and towards mortality are colored by their previous experiences. So, for example, if someone's father, he had a heart attack at say 50 years of age, at the age of 50, there is an unexpected anxiety. So there is a background to their fear, while doctors, because of the training, we talk in terms of probabilities. For that patient, the anxieties may be very different. So we may have very different perspectives. For example, in relation to mortality. The context of illness. For us, it is quite naturally a biological phenomenon requiring medical intervention. For patient, illness changes their entire lives. For endocrine chronic diseases, this is even more relevant, as Dr. Rishi had already mentioned, the lives of type 1 diabetes and type 2 diabetes, of course. Having a chronic illness completely changes their social identity, how people look at them, for example, how they will be perceived when it is known that they have diabetes. So the context of illness is different for doctors and patients. The beliefs of disease causalities are also different. You may want to emphasize to the patient that diabetes is caused by changes in the pancreas. There are 8 different organs. There is octet theory, but the patients will be still stuck on the thing that maybe I did this wrong and therefore I had this. Maybe that even precipitated this. The concept of causality and understanding the complex nature of disease causality is not easy to apprehend. Even for us, it is difficult to understand. For patients, it's a very new concept. And they still try to find why this happened to me. And that why is a very troubling question for most patients with type 1 also. They keep on figuring out one single causal event which led to the diagnosis. So when the ideas of causality are conflicting, care may be compromised because of that. And of course, one of the important things are shame, blame, and fear. I think the way we have been trained, and for example, a person who now has a really uncontrolled diabetes, HbA1c is very high on multiple drugs, and he or she needs insulin. So this week I had a patient who had HbA1c of 11% on maximal drug, and she needed insulin, and she flat refused that I am not going to take insulin. And so usually the younger me would have responded by saying that, no, you require insulin because it is important, otherwise it's going to affect your health, all that. So there is a kind of, and there was another patient who kind of gave history that he's taking this glimepiride twice a day, metformin twice a day, and his HbA1c was still 11%. While 3 months back, his HbA1c was good. And we kept on asking what happened in these 3 months. Something happened in your lifestyle. He didn't come up with the answer. Then I just asked whether you're taking those medicines, and wife kind of shyly revealed that he has been taking Ayurvedic medicines, so he reduced the dose and he's not taking the night dose. So the patient obviously was ashamed of acknowledging that he wanted to control his diabetes, taking some alternative therapy, and that didn't work. And it is a huge shame for them. So reacting to that in a similar manner or blaming them for not being compliant to that won't help. So other way around, we may have to find some other way of communicating. For example, maybe saying that, see, you're doing good in all other aspects of your life. I think we learn from our mistakes. So there may be a way of communication which we learn with time. Of course, shame, blame, creating fear doesn't work in both cases, in doctors or in patients. So these were the 4 divides which narrative medicine claims to address. And there is the 7C approach which has been proposed to redress these divides, how to reduce this gap between patient and doctor. So the 7 C's, the first C is conversation. And what is meant by conversation? A clinic visit is always a conversation. The doctor allows the patient to express his or her story adequately and in his or her own words. That doesn't mean that we're just sitting there and not listening, or maybe the mind is drifting here and there. It is with deep interest in their history, but at the same time exploring connections, differences, new options, new probabilities, probing, guiding the conversation. So we have to still guide the conversation to get what the patient's story is exactly. Not every patient is eloquent enough. Sometimes the stories may not be explicit also. So with time, I think, and here comes the role of maybe not just training doctors in medicine, but also maybe having literature as a subject so that we understand nuances of stories, because stories are told in so many ways and not just words. Not everyone has proper expressible capability. While when these stories are being said in this manner, understanding is created between doctor and patient by virtue of the conversation. And then a management plan can be agreed upon rather than something which is imposed on the patient. So more often than not, endocrinology involves management plan, which needs the patient to actively be involved in the management. They need to make some changes in their lives. For that, it is understand what their identity, what their lifestyle is, and how to fit in the new management plan within that context. Such conversations flow naturally and might continue from one consultation to next. So time is always a hassle, but it's not necessary to finish the whole conversation in one time. We can always divide it into 2-3 visits, and patients are invited to see change as a realistic possibility. So some examples of how one may guide the conversation is maybe prompting the patient. If for example, she's saying that I don't want to take insulin, so tell me more. What is worrying you most about insulin? Is this something that you're worried about? So maybe they'll come up with a story. So this lady I was talking about, her reason was not that she was afraid of needles or she had some beliefs about insulin. Her fear was that if I take insulin, my husband and my sons, they will tell me that it's because you have not taken good care, you were not following your diet, you were non-adherent. So she has a fear of what they will say, and therefore the whole conversation changed after that. And then the idea was to talk to the husband and tell him that this is like, it's not her fault, and that framing changed. So there are other questions depending on what the patient is saying. Has this ever happened before? What else was happening at that time? What do you think about this? So I think these kind of inquisitive questions, a person coming with new onset diabetes, we can maybe first try to understand, how do you feel about having diabetes? What does this mean to you? What do you think might be causing this? How do you describe? What is your concept about your diabetes? So I think letting the patient come up with their stories before we kind of brush it off with what our ideas of his or her disease is probably important. Curiosity. The second C is curiosity. This is not about trying, but having genuine interest in patients and wanting to understand more about them and their circumstances. However, and this has really helped me quite a lot, curiosity also extends to the doctor's own personal feelings and emotions. When a person walks in, sometimes we are on defensive, and it's important to analyze our reaction and being curious of why I am feeling like this. That is going to help in improving the quality of conversation. Context. Context is pertinent to both patient and doctor. The family, work, community, what is the profession, what are the beliefs, expectations. And it's a useful question to ask, why has this patient presented at this moment with this problem? A patient may be having diabetes for 4 years, not taking any medicine, but suddenly one day it'll come that now I want to start medication. So what has happened? What caused this change is an important question to ask. It's also good to have a sense of complexity. Things are never straightforward. And having this sense of complexity helps us understand that behavior change may not happen in a day. Sometimes a person may be coming for a year, 2 years, without changing any lifestyle. So an elderly lady, 60-year-old, she was coming to me for many years, and her weight was not coming down. She would just not go out for a walk. Suddenly one day she came and she had a lot of hypos. Her insulin was stopped. Still she was having hypoglycemia. She had started walking out of. So all these, every visit conversation and what is hampering your walk. So you never understand what will motivate them and how the story changes. Something may work for them. So keeping that option open, being optimistic about possibility of change in future is important. Keeping a sense of complexity is important. Also, fifth C is challenge. It is important to challenge the patient and oneself to consider new ideas. When we listen to patient stories, it's not that we agree to all their ideas. We can always counteract that by saying, is there any other possible explanation? How else might you want to explain this? What do you think would happen if you start this treatment? So there are some questions which can be used to challenge their notions. Sometimes the challenge can be towards yourself also. So I think challenge is another important C. Sixth is caution. it is also necessary to have an awareness of one's limitations and be sensitive to the patient and his or her needs, including willingness to go into unexplored areas and readiness for change. So I think that's important. And the most important C, I think, is care. Care requires being non-judgmental and accepting patients for who they are. Nothing can be achieved if the doctor does not genuinely care about the patient. So the most important C in the 7 C's is care. So moving from 7 C's, how to implement narrative-based medicine, to power of narratives. How would narrative medicine help? So number one, just telling the story may be therapeutic, just unburdening. It's intrinsically therapeutic for many patients. It prevents the disconnect that might otherwise occur between doctor and patient. Sometimes the first or second visit, the patient may take a lot of time, but the consequent visits may become more and more simpler because of the improved bonding, and it promotes deeper understanding of the patient. It helps develop empathy, improves rapport, strengthens doctor-patient relationship. So these are important goals actually in management. The most important thing which I think narrative-based medicine helps with is it shifts the focus to patient narrative. So previously, immediately after training, and for many years, how we would react is, okay, a person with diabetes is coming, I have to check the HbA1c and correct it as quickly as possible. So we have been trained to problem solve. In all our training, we are trained to give answers. If some question is asked, we have to give a diagnosis, we have to give an answer. And we are not comfortable with questions and problems staying unsolved. And I think narrative-based medicine might help in changing that. Not all problems can be solved. Not all questions need to be answered then and there. The idea is to focus on patient narrative, listen to them, understand their problems, and don't think yourself as a fixer of their problems, because that is where the problem starts. You can sometimes also say that maybe I won't be able to fix your problem, but I'm ready to listen and understand still. When using narrative skills, the doctor is in a better position to empathize with the patient's plight and ultimately to improve health outcomes, opening a path towards healing, even in complex and challenging situations. There are situations where you may not be able to provide solutions. We understand our limitations, we understand the limitations of medicines, and that brings a lot of humility in conversation. So I'll end with this, one of the favorite quotes. 1 second, I can't see the first line. I'll start with the second, third line because it's being blocked. So helping, fixing, and serving are 3 different ways of seeing life. When you help, you see life as weak. When you fix, you see life as broken. When you serve, you see life as whole. Fixing and helping may be work of ego, and service the work of the soul. So this is by a physicist, Rachel Naomi Remen. This is from a book called Kitchen Table Wisdom, How to Tell Stories. So it's a wonderful book, I think, for all physicians to go through. With that, I end this presentation on narrative medicine.
Thank you, Dr. Beena Bansal. That was a wonderful lecture. Thank you for bringing in the power of narrative medicine, and also the thought that the doctor's thoughts could itself, change as during an interview with the patient. So that was very fascinating. Would like to ask Dr. Vaishali, Dr. Sonali, is there time for questions, or should we go to the next session? Dr. Vaishali, we had wonderful speakers.
Yeah, I know. You can take a question, single question. If there is any.
Yes. So, is there a question from the audience?
I don't know whether there are any on the chat box, if you can see.
No, there are none on the chat box as far as I can see.
If there are no questions, we will move on to the next session. Thank you all for being here. It was lovely listening to all the research modalities that have been occurring with MBM. So over to you, Devang.
Thank you all.
Bye-bye.
And thank you.
Thank you.